Good evening, sir. Good evening, Parvati.
Good evening. Good evening. Good evening. ഈ പറഞ്ഞ പോലെ ഈ സമയത്ത് കയറുക എന്നുള്ളത് പ്രധാനമായിട്ട് എന്തെങ്കിലും കാരണവശാൽ ഈ പറഞ്ഞു വരാൻ പറ്റില്ലെങ്കിൽ ശരി, വരികയാണെങ്കിൽ ഒരു നിവൃത്തി ഉണ്ടെങ്കിൽ താമസിക്കരുത് എന്നുള്ളതാണ്.
നല്ല കാര്യം. കുട്ടി വരണല്ലേ നമ്മുടെ ഡോക്ടർ എലിസബത്ത്.
പാർവതിയാണോ പ്രസന്റ് ചെയ്യുന്ന ആള്?
പാർവതിയാണ് പ്രസന്റ് ചെയ്യുന്ന ആള്.
അസീസിയ അല്ലേ? അസീസിയ അല്ലേ?
സാർ നന്നായിരിക്കുന്നു. ഡൂയിങ് വെൽ.
ശരി. അന്ന് നിങ്ങൾ രണ്ടുപേരും വന്നിരുന്നല്ലോ അല്ലേ പ്രിസൈസിന്റേതിന്?
വന്നിരുന്നു.
ഞാൻ ഉച്ചയായപ്പോ പോയി.
ഉച്ചയായപ്പോ ഞങ്ങളും പോയി സാർ.
ഈ സൺഡേ ഒരു കൂട്ടം കാര്യങ്ങളാണ്. ഇതൊന്നും വരാതിരിക്കാനും പറ്റത്തില്ല. നമ്മുടെ ജോലികളെല്ലാം പെൻഡിങ് ആവുകയും ചെയ്യും.
എക്സാക്ട്ലി. ഞങ്ങള് സാറ്റർഡേ കൊല്ലം ഓഫ്താൽമിക് സൊസൈറ്റിയുടെ മീറ്റിംഗ് ഉണ്ടായിരുന്നു. അപ്പൊ അതിന് പോയി. നെക്സ്റ്റ് അടുത്ത മീറ്റിംഗ് ഇതായിരുന്നു.
എല്ലാ വീക്കെൻഡും എന്തെങ്കിലും പരിപാടികളുണ്ട്. അതുകൊണ്ട് ഒരു നിവൃത്തി ഉണ്ടെങ്കിൽ പങ്കെടുക്കേണ്ടതെല്ലാം പങ്കെടുക്കുക എന്നുള്ളതാണ്. നമ്മുടെ മറ്റേ കുട്ടിയെ കണ്ടില്ല,
എലിസബത്തിനെ കാണാനില്ലല്ലോ.
അതെ അതെ. പാർവതി ഏത് ഇയറാണ്?
സെക്കൻഡ് ഇയർ.
എവിടെ പഠിച്ചതാ? യുജി എവിടെ പഠിച്ചതാ?
ഗോകുലം മെഡിക്കൽ കോളേജ്.
എവിടെ?
ഗോകുലം മെഡിക്കൽ കോളേജ്.
Good evening. Hello. കേക്കാമോ?
Good evening.
മാഡം,
ഞങ്ങൾ എലിസബത്തിനെ കണ്ടില്ലല്ലോ എന്ന് പറഞ്ഞോണ്ടിരിക്കുവായിരുന്നു.
ഞാൻ പിള്ളേർക്ക് ഭക്ഷണം ചൂടാക്കി വെക്കാൻ പോയതാ, അല്ലെങ്കിൽ ആ സമയത്ത് അവര് വിശന്നിരിക്കും.
നന്നായി.
പാർവതി, പാർവതി ഷെയർ ചെയ്യാലോ അല്ലെ വീഡിയോ? പാർവതി
ഡിസേബിൾ പാർട്ടിസിപ്പന്റ് സ്ക്രീനിങ് എന്നാണ് സ്ക്രീൻ ഷെയറിംഗ്.
അത് ഇപ്പൊ ശരിയാക്കി തരാം.
എലിസബത്ത് ഇങ്ങനെ എല്ലാവർക്കും വന്നവർക്കൊക്കെ ഒരു വെൽക്കവും പറഞ്ഞ് ഇന്നാരാണ് ശിഷ്യ, ഇന്നാരാണ് ഗുരു, സ്റ്റാർട്ട് ചെയ്യാന്നൊക്കെ പറയണം.
പറയാം സർ, ഒരു മിനിറ്റ് സർ. Good evening, everyone. Today we are going to have the case discussion on glaucoma case, pseudoexfoliation glaucoma, and our Dr. Smita Narayanan is our chairperson for the discussion, and presented by Dr. Parvati from Assisia Medical College. So can we start the presentation, Dr. Parvati and Dr. Smita, madam? Can we start?
Yes, you can start.
Is the screen visible?
Yeah, it is seen.
Good evening, everyone. So coming to the case presentation, Hassan Kunya, 69-year-old male from Ayur, working as a farmer. Presenting complaint, diminution of vision, right eye for the last 2 years. History of presenting complaint. Patient presented with complaints of diminution of vision, right eye for the last 2 years. It was gradual in onset and progressive in nature. Patient also gives history of frequent change of glasses. No history of associated pain, redness, nausea, colored halos, photophobia, flashes of light or floaters. No history of trauma to right eye. No history of exacerbation of symptoms on exercise. No history of use of steroids. Past history. He is a non-case of diabetes mellitus on oral hypoglycemic agents. No history of hypertension, dyslipidemia, bronchial asthma, coronary artery disease or CV in the past. No history of migraine. No history of ocular surgeries in the past. Family history. There is no relevant family history. Personal history. Patient takes non-vegetarian diet, normal sleep and appetite, normal bowel and bladder habits, no addictions. Drug history. Patient is on oral hypoglycemic agents, metformin 500 mg BD and glimepiride 2 mg OD. No history of drug allergy. Coming to general examination. Patient is conscious, cooperative, oriented in time, place and person, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, blood pressure 130/80 mmHg in right upper arm in supine position. Pulse rate 78 per minute. Regular rate, rhythm, volume. Bilateral carotid pulsations felt equally, no brewing. Febrile. Respiratory rate is 20 per minute, abdominothoracic. Systemic examination. Respiratory system, normal vesicular breath sounds heard bilaterally, no added sounds. Cardiovascular system, S1, S2 heard, no murmur. Central nervous system, higher mental function with the normal limits, no focal neurological deficit. Gastrointestinal system, per abdomen soft, non tender, no organomegaly. Ocular examination, head posture normal, no facial asymmetry, orthophoric, ocular movements full and equal in all directions, both eyes, confrontation test normal in both eyes. Vision, right eye visual acuity 6/60 and best corrected visual acuity 6/12. Left eye visual acuity 6/9 and best corrected visual acuity 6/6. Color vision with Ishihara chart is normal in both eyes. And near vision, best corrected near vision is N6 in both eyes. Examination of right eye, lid and adnexa are normal, conjunctiva normal, no congestion, size and shape, no epithelial or stromal edema, no pigments or pseudo-exfoliated deposits on the endothelium, corneal sensations normal, anterior chamber VH grade 3, no cells or flare, iris, pseudo-exfoliated material seen in the pupillary margin. There is loss of 270-degree pupillary error, no transillumination defects, no peripheral arterial synechiae, atrophic patches, neovascularization of iris, or evidence of peripheral iodotomy. So in the image, you can see pseudo-exfoliated material at the pupillary margin along with loss of pupillary error. Pupil, central in position, round in shape, size 3 mm. Lens, pseudo-exfoliated material seen over the lens after dilatation, nucleus sclerosis grade 3. Intraocular pressure with applanation tonometry was 22 mmHg, and conioscopy showed open angle, pseudo-exfoliated material at the angle, and increased uneven pigmentation of trabecular meshwork, and sambiolate line was visible. In the image, there is pseudo-exfoliated material on the anterior lens capsule. Fundus examination done using slit lamp biomicroscopy and 9 lens, and periphery examined using indirect ophthalmoscope and 20 lens. Vertically oval, average size disc of 1.69 to 1.56 mm size. Margins are well defined. CDR 0.7. Neurorectal rim is pink, no notching, ISND rule followed. No disc hemorrhage, no parapapillary atrophy, no bearing of circumciliary vessels, nasalization of vessels of lamina dot sign, no Arneffel wedge defect, AV ratio is 2:3, no AV crossing changes, macula is normal with foveal reflex present, and periphery up to ora serrata normal. Diagonal fundus image. Examination of left eye, lid and adnexa normal, conjunctiva normal, no congestion, cornea clear, normal size and shape, no epithelial or stromal edema, no pigment or pseudo-exfoliated deposits on the endothelium, and corneal sensation normal. Anterior chamber Van Herrick grade 3, no cells or flare, iris normal color and pattern, no pseudo-exfoliated deposits seen. Pupil is central in position, round in shape, size 3 mm. Lens nucleus sclerosis grade 2. Intraocular pressure measured with applanation tonometry was 16 mmHg. Conioscopy showed open angle, Schaffer's grade 3. And fundus examination done using slit lamp biomicroscopy and 90D lens, and periphery examined using indirect ophthalmoscope and 20D lens. Showed a vertically oval average size disc of 1.69 to 1.56 mm size with margins well defined. The cup-test ratio was 0.4. Neurorectal rim is pink, no notching, ISND rule followed, no disc hemorrhage, no parapapillary atrophy, no bearing of circumciliary vessel, nasalization of vessel or lamina dot sign, no Arneffel wedge defects, AV ratio is 2:3, no AV crossing changes, macula is normal, FR present, and periphery up to ora serrata normal. Summary. 69-year-old diabetic male patient presented with complaints of painless progressive diminution of vision in the right eye for the last 2 years. On examination, best corrected visual acuity in right eye was 612 and 6:6 in left eye. Color vision was normal in both eyes with Ishihara chart. Right eye showed pseudo-exfoliated material in pupillary margin and lens with loss of pupillary error, NS3 cataract, and IOP measured with applanation tonometry was 22 mm. Conioscopy showed open angle with pseudo-exfoliated material at the angle. Pigmented trabecular meshwork and sambiolate line was seen. Fundus examination showed CDR 0.7 with pink NRR, no Arneffel wedge defect, macula and periphery with a normal image. In left eye, anterior segment was normal with NS2 cataract. IOP with applanation tonometry was 16 mmHg. Open angle on gonioscopy and fundus showed CDR ratio CDR 0.4, macular and periphery with a normal. Probable diagnosis pseudoexfoliative glaucoma. And my differential diagnosis are pigmentary glaucoma and primary open angle glaucoma.
Okay, Parvati. You have made a presentation where you have seen some pseudoexfoliative material and you have made a straightforward diagnosis of pseudoexfoliative glaucoma. So I think there are a few things which have to be addressed in your presentation. And I think we will go from your slide, each point that you have presented, we will discuss each of that. So show me from your first slide. And I request Dr. Elizabeth to please shut off her mic. So next slide, please. So the first complaint was the decreased vision, diminution of vision in the right eye. So do you think, what do you think is the cause of decreased vision in your patient's eye?
It may be due to cataract.
It may be, it is due to cataract.
Cataract.
So in your diagnosis, you must state that the patient has nuclear sclerosis of grade 3 in the right eye. And you did not even mention the eye in the diagnosis. So please see to it that you have to mention the nuclear sclerosis grade 3 right eye along with your diagnosis of pseudoexfoliative glaucoma. And also that patient was diabetic and there is cataract in the other eye also. Those things have also to be mentioned in your diagnosis.
Okay.
Okay. So please see to it that if you show me your diagnosis, the slide with diagnosis, show me that slide. Provisional diagnosis. Yeah. See, you did not mention the eye. You did not mention the cataract. You did not mention the systemic condition. So those things are very essential when you are presenting. Okay. So that is one thing. And then let me ask you a question. Let's go to that first slide which you had presented, third slide. Next, before that, okay. Do glaucoma patients present with decreased vision?
If it's an acute congestive glaucoma?
Yes. Or any other condition? Dr. Elizabeth, please mute your mic.
It's already muted, ma'am.
No, it is not. So, Parvati,
Yes,
do glaucoma patients present with decreased vision? You told me that primary angle closure glaucoma can present. Any other condition? Any other glaucoma? So secondary glaucomas also can present with decreased vision. Okay. So which glaucoma will not present with decreased vision?
Primary open angle glaucoma.
Yes. So primary open angle glaucoma is the one which will not present with decreased vision. So how does it present?
Usually asymptomatic.
Correct. Usually the patients are asymptomatic. Only in very advanced cases, you will have field defect. What is the very advanced field defect that you see in primary open angle glaucoma?
Channel vision, then temporal vision, field of vision. Temporal island of vision.
Tubular field with a temporal island of vision.
Island of vision.
That's how it is described. So what do you understand? That glaucoma is a silent thief of sight. These people are totally asymptomatic. So now if these patients are asymptomatic and they will not come to you because they have no symptoms, so how will you get those patients?
As an incidental finding, when you observe this.
So incidental finding means many of the patients will be missed. So it is very important, and I want to emphasize it further and further, that you you should always examine the intraocular pressure and the fundus of every patient who comes to you for an ocular examination. Understood? Then only you can diagnose primary open-angle glaucoma, because it is an asymptomatic condition. So all the patients who come should have their intraocular pressure measured and should have an optic disc examination done. Now let's go to your next slide. In your history, you said that the patient gives history of frequent change of glasses. Why did you say that? What does that signify? Can you hear me?
Yes, ma'am.
Okay. So why did you give that history of, patient gives history of frequent change of glasses?
In primary open-angle glaucoma and pseudoexfoliated glaucoma, patient can give history of frequent change of glasses.
So how does that happen? Why should that happen? Would any of the PGs like to comment on that? Any other PGs? Devi?
Madam, due to the defective accommodation, the ciliary.
So what I want to emphasize is, both for you also, Parvati, these patients with primary open-angle glaucoma have frequent change of presbyopic glasses, not of their distance vision. It is of the presbyopic correction. So your patient is about 70. So that patient will not have frequent change of presbyopic glasses because of intraocular pressure being high. Because the accommodation will be effective when the intraocular pressure is high, because a 70-year-old would have lost most of his accommodation. His ciliary muscle would not be working. So what do you think are the reason? What do you think is the reason in your patient? Why is your patient requiring frequent change of glasses?
Cataract.
Yes. So it is a nuclear sclerosis, which is causing frequent change of glasses. Okay. Your patient also has diabetes. So diabetes also can cause change in the refraction of the eye. Okay. So another thing that I want to emphasize to you when you are presenting is that once you have examined the patient, you may have to go back to the patient to take more points in history or more points in examination. Okay? So, ഒരു പ്രാവശ്യം കണ്ടു കഴിഞ്ഞാലും പിന്നെയും ആ പേഷ്യന്റിനെ ഹിസ്റ്ററി എടുക്കാനോ എക്സാമിനേഷൻ ചെയ്യാനോ പിന്നെയും നോക്കേണ്ടി വരും. So once you have done a gonioscopy where the angles are open, then your job is to find out whether the patient has a primary glaucoma or a secondary glaucoma. Secondary open angle glaucoma. So how do you know that the patient has a primary glaucoma?
When there is no other associated feature.
So you have to rule out all the causes of secondary glaucoma. And if on your slit, on your gonioscopy, you have found that the angles are open, then you have to rule out all the causes of secondary open angle glaucoma. Understood? Yes. So what are the causes of secondary open angle glaucoma? Can you tell me some of the causes? Or what are the causes? Yes, okay.
Pigmentary glaucoma.
Okay.
Steroid-induced glaucoma.
Steroid-induced glaucoma, very good. Look at your slide. You can see one more.
Angle recession glaucoma.
Okay, angle recession glaucoma or glaucoma post-trauma. Then any other conditions? Can any of the PGs add? Can any of the PGs add?
Neovascular glaucoma, opening.
Neovascular glaucoma. Good. Anything else? Any other open angle glaucoma? Could there be something in the lens?
Phacolytic glaucoma.
Phacolytic glaucoma. Okay. Anything else? Can a subluxation of a lens cause a glaucoma?
Yes.
Associated findings, associated features along with subluxation of lens can cause a glaucoma. Can there be uveitis which can cause a glaucoma? So or can there be a surgery which can cause a glaucoma? Parvati? Can glaucoma occur after cataract surgery? Secondary glaucomas?
Yes, ma'am.
Yes. So your history should tell me about all these things. That there is no history of any surgery in the eye, there is no history of trauma or steroids, which you definitely have said. Okay. So there is no need to tell me about no history of associated pain, redness, nausea, because that is indicative of an acute
Angle
attack of angle closure glaucoma. We are going to discuss only open angle glaucoma today. Understood? By your gonioscopy, you have ruled out that it is only open angle glaucoma. So do not include angle closure into this. Okay.
Okay.
So why did you say there is no history of exacerbation of symptoms on exercise?
Pigmentary glaucoma.
So pigmentary
Exercise
glaucoma.
exercise can cause increased release of pigments.
Correct. So this is why I'm saying you may have to revisit your history in your examination multiple times. Okay. Then let us go to the next slide. You also have to tell whether the patient is on any anti-glaucoma medications or not. And if the patient is on anti-glaucoma medications, you also have to tell about the side effects of those anti-glaucoma medications. If you have asked all of these things, then the examiner knows that yes, this student knows what to look for. So there won't be much questions. Okay?
Okay.
Okay. So now come to the next slide. Okay, next slide. Let's go to the examination. Yes. So this is okay. Visual acuity. So your visual acuity is -2 sphere, -1 cylinder, 90 degree. So what type of a cataract is indicated by that? What type of cataract will show a minus power? Any of the PGs?
Nuclear sclerosis.
Yes, nuclear sclerosis will show a minus power. Okay, so your patient also has nuclear sclerosis. And Parvati, what is the commonest cataract, that kind of cataract that is associated with pseudoexfoliation?
Nuclear sclerosis.
Yes, nuclear sclerosis. Okay. So now this is all good. Let's go to the next slide. Okay. So when you're looking at each of these structures, you have to eliminate secondary glaucoma by your examination. So which secondary glaucoma can you eliminate by looking at the conjunctival vessels? Any of the senior PGs?
We look for circumcorneal congestion, rule out the acute and
No, we are talking about open angle glaucoma.
raised episcleral venous pressure.
Yes, you can rule out episcleral venous pressure. So what type of vessels are seen on the conjunctiva?
Corkscrew vessels.
You will see corkscrew vessels. So Parvati, look at the conjunctiva. You have to give a negative history also, that there were no corkscrew vessels seen. So you will be eliminating that kind of condition. Then you are looking at the cornea. You have done a good examination. You also can add if there were no KPs in the patient's eye. Okay.
Okay.
So that way you are ruling out what kind of glaucoma?
Uveitic glaucoma.
Uveitic glaucoma. Now you're coming to anterior chamber. So your patient has pseudoexfoliation. So what can happen in the anterior chamber, to the depth of anterior chamber? You have just written VH grade 3. Okay. So what can happen to the depth of anterior chamber?
It can be normal or decreased.
It can be normal or decreased or
Irregular.
irregular. Very good.
Irregular.
Very good. It can be normal or decreased or irregular. Now, can you tell me why it could be irregular?
Lens subluxation.
If there is a subluxation of the lens. So it is very important that we compare the anterior chamber depth of this eye with the other eye and also compare the nasal and temporal aspects of the same eye also. Then only you can understand that it is irregular in depth. Okay? And you've written no cells and flare. So why did you write that?
One uveitic to rule out uveitic glaucoma. Then in pseudo exfoliation, flare is seen.
Yeah, in pseudo exfoliation, flare is seen. Because why is the flare seen?
The pigments, there will be melanin dispersion.
Melanin dispersion happens more in pigmentary glaucoma, though it can happen in pseudo exfoliation also. The flare is seen because of the breakdown of
Blood access barrier.
Yeah, you should know that. Huh? Okay. Now, what about your iris? So be careful when you are writing all these things. Huh? What are you looking for? You have to exactly tell me that. And the eye, then look at the iris. What will you see in the iris? You've written that it is seen on the pupillary border and lots of things. But in the iris, you also have to look for iridodonesis. Understood? Huh? Because pseudo exfoliation will damage these zonules and the patient may have iridodonesis. Let's go to the next slide. Okay, good. Next slide. So here you've written about the pupil. So Parvati, one of the most important things about the pupil is that you should always write the pupillary reaction.
Okay.
You should, as an ophthalmologist, that is very important. Excuse me. That is very important. So pupillary reaction, both direct and consensual, for each eye must be written. Okay.
Yes, ma'am.
And you also have to tell us whether the pupil dilates well or not.
There was poor dilatation, ma'am.
There was no?
There was poor dilation, poor to moderate
You
dilatation.
have to tell us that. That is important, isn't it?
Yes,
So that is something which you have to tell us here. So now you told me that there was a neovascularization not seen, is it?
Yes,
You told something about neovascularization in the iris or pupil or
Iris.
somewhere. So that was good that you did not see neovascularization in this patient's eye. So that is one other point that is important. Now in the lens, you have been very casual, pseudo exfoliative material seen over the lens, even though your picture was so descriptive. Show me that picture. Yeah. So can you see the pseudo exfoliative material in the center of the lens? Then can you see the clear area? And then can you see that there is again pseudo exfoliative material? So you should have described that. Huh? So what is that sign called?
Target.
Yes, very good. So that is called the target sign, and that is important. Then you also have to tell me whether there is phacodonesis or not.
Yes, ma'am.
That was very important.
Yeah.
And see, there are other things which the lens can cause a glaucoma because of the lens, like your subluxated lens or phacolytic glaucoma. But that is not there because it is not a cortical, not a mature cataract. Okay, that's important. The next slide, please. The one before, you had written about the intraocular pressure. So intraocular pressure, you've written it is with applanation tonometry. Usually, we also give the time when it is measured.
Okay.
So because mostly in open angle glaucoma, sometimes we may have to look for a diurnal variation. And since we find it very difficult to do a 24-hour monitoring, we do something called an office diurnal. An office diurnal means you are measuring it sometimes when you are working, when you as a clinician are working. Okay. Now look at the gonioscopy. So now tell me, How do you do a gonioscopy? What lens do you use?
Goldman.
Goldman. How many mirrors? Whichever you have used, that's okay.
Two-mirror
Whichever
gonioscopy.
you're using a Goldman 2-mirror gonioscope. So what are the precautions that you utilize when you're doing a gonioscopy?
Anesthetize the corner.
In the mullet? Say that. What are the steps or what are the precautions that you use when you're doing a gonioscopy?
It has to be done after application tonometry.
Why do you say that? It can be done. Okay, whatever. But why do you say that?
After gonioscopy, the angle can open. So the IOP will be low.
Okay. Okay, that is okay. Now tell me what are the precautions you will utilize while performing gonioscopy? Can any of the PGs tell me?
Should be a
You
dark.
know it, Parvati, but okay, Devi, please tell me.
It should be a dark room.
It should be done in a semi-dark room. Good. One.
Then you have to educate the patient well. You should
Educate what?
regarding to place the face still in the slit lamp, how we are going to perform the procedure.
Okay.
Explain the procedure to the patient and apply topical anesthesia. First, the angle should be examined in the primary position first. In the narrow beam should be used.
What do you mean by narrow beam?
2 into 2 mm.
Correct.
Ideally should be to be used, and making sure that it does not fall over the pupil.
Very good. Why? What is the problem if it falls on the pupil?
It can falsely give you an open angle while doing
Yes.
the gonioscopy.
So, Parvati,
Yes, sir.
do you understand? These are the precautions that you use when you're performing a gonioscopy. Okay. So when do you say that the angles are open? Open is actually non-occludable. When do you say an angle is non-occludable?
Grade 3 or 4. If the shawl is like trabecular meshwork is
Which one? You said two structures. Which one should I consider?
trabecular meshwork.
Which trabecular meshwork?
Pigmented.
Pigmented.
How much?
270 degrees.
It's 180 degree. If you can see pigmented trabecular meshwork in more than 180 degree, it is an open angle or a non-occludable angle. Okay. So you have written that it is pseudo-exfoliative material seen at the angle. What makes you think it is pseudo-exfoliative material?
Whitish flaky material.
Yeah. So there are some whitish. So how does the angle appear? How is it different from the gonioscopic appearance of a pigmentary glaucoma?
Here there will be uneven pigmentation.
Yes, uneven pigmentation. It's like a salt and pepper pigmentation. Whereas in pigmentary glaucoma,
Uniform thick and pigmented band.
uniform dense pigmentation will be seen. Okay. Then you have written Sam-Policy line is visible. What is this Sam-Policy line?
Pigmentation at the shawl base line.
Pigmentation?
At or anterior to shawl base line.
Pigmentation anterior to the Schwalbe's line. Okay. So this is a distinct line as compared to the Schwalbe's line. Okay. So how will you identify that this is anterior to the Schwalbe's line?
Corneal wedge method.
Eh? I'm sorry, Rashmita, once again.
Corneal wedge.
So you will use a corneal wedge technique. Do you know how to do the corneal wedge, Parvati? Hello? Hello, Parvati.
Yes,
Yeah. Okay. So you have now told me about most of your findings. Then you also have to mention that there are no new vessels in the angle. New vascularization is not there in the angle.
Yeah.
Okay. That is also important. And it is also important to mention about the iris configuration. Is it a plain iris or is it a convex iris configuration or is it a concave iris configuration? Why? Especially in your case, why?
There can be concave iris configuration seen in pigmentary glaucoma.
Very much, yeah. So therefore, the concave iris configuration is seen in pigmentary glaucoma. So that is very good. Let's go to the next slide. Next slide. Yeah. So now you have examined the fundus. Okay. So you have told me that this is a vertically oval average size disc. So Parvati, whenever you do a fundus examination, either by indirect ophthalmoscopy or by any other technique, the first thing you have to comment about is the media through which the light is passing. So you have to tell me whether the media is opaque or media is clear. All of those things are important. In your case, the media will be slightly opaque or slightly hazy because of
Nuclear sclerosis.
Because of nuclear sclerosis. You have written that the disc is vertically oval and you have given a size. So how did you measure that?
With 90-degree lens and
Yes.
slit lamp.
Yeah.
The slit beam size is adjusted
Okay.
to cover the vertical diameter of the disc.
To cover
And
the
then-
vertical diameter of the disc. And then,
That is multiplied by a multiplication factor of 1.3.
okay. So
It's
how
90
did you
direct.
know the height of the slit beam? Where was the height of the slit beam written?
There's a marking on the slit lamp.
There is a mark. Yeah. So some of the higher end slit lamps have a scale provided along with it. So they give you a marking of how much is the height of the beam. And using that, you will use this. You can measure the size of the disc. But there are plenty of slit lamps where you do not have the scale to measure the size of the disc. So it is best to say the disc is large or small or average in size. Okay.
Okay.
So your disc is an average size disc. You've written it correctly. Your disc is average size disc. So tell me, why should you know about the size of the disc?
Because large disc will have large cups.
Large disc will have large cup. Is it so? Is it necessary? So a small disc will have a small cup and small disc will not have a large cup. Is it so?
No, ma'am. It is normal to have normal for a large cup in a large disc.
See, in a small disc, even a 0.4 or a 0.5 cup would appear much larger. So you have to be very much aware about the size of the disc, because in a large disc, a 0.4 cup would not be significant enough. But a 0.4 cup or a 0.5 cup in a small disc would be very significant. That would mean that the neuroretinal rim has been very much damaged. Then you have looked at the neuroretinal rim. You've told me that it is pink and there is no notching. Why do you look at the color of the neuroretinal rim?
To look for any pallor.
Why do you want to know about pallor?
Pallor is usually seen in normal tension glaucoma or a neurological process of glaucoma.
Yeah, pallor is seen in neurological diseases, which may show some amount of cupping, and you will be confused. So pallor is more important to rule out a neurological condition. Can you tell me some other tests which will help you to rule out a neurological condition? Something else
Visual
that
field.
you have done?
Visual field.
Visual field. So what is different in the visual field? You did
Um,
not do the visual field though.
Visual field defect will follow a vertical meridian.
Okay. Anything else which will tell you that this is more likely to be neurological? You have done 2 tests. You have done 1
It will
test.
be not corresponding to the discharges. It will not correlate with the discharges.
That is the field. Anything else? Any other test?
Color.
Yes, you have looked at the color vision. Color vision will be damaged
Neurological condition.
in neurological conditions. Okay.
Yes, sir.
Yes. Now you told me that the ISNT rule is followed.
Yes, sir.
So, is there glaucoma in your patient? Is the ISNT rule applicable to all patients?
Yes, sir.
It's applicable to all patients. ISNT rule is applicable only in about 70 to 80% patients. Okay, so it's not in your patient, the ISNT rule is followed even though there is a 0.7 cup. So that is important. What do you mean by this no bearing of circumciliary vessels?
When the cup receives, the vessels will be seen as isolated.
Yeah, there will be no support to the vessels. Those are very important. So it's, say today you have seen a vessel at the margin of the cup, and 4 months later or 6 months later, you may see a cup where the vessel has remained there, but the cup size has increased. So the vessel is now sort of freely floating. So that is called bearing of the, there's no support for the vessel. That is called bearing of the circumlinear vessel. You told me that there are no RNFL wedge defects. How do you look for the RNFL wedge defects?
In red-free filter.
Using a red-free filter. What is the color of that filter?
Blue or green.
Blue is different.
Blue.
It is a green filter. Where do you use the blue filter? In the slit lamp. Where do you use the blue filter? You must be using it.
Epithelial.
Yeah, when you're staining with fluorescein, you have to use a cobalt blue filter, isn't it?
Yes.
So why do you say your patient has glaucomatous disc?
There is increased enlargement of disc in right eye, and there is cup asymmetry between the two discs.
There is enlargement of the disc between the two eyes, and there is asymmetry between the discs. That is good. So that is why you see. So there is a suspicion of glaucoma. So now, after all this discussion, how would you state your diagnosis?
There is pseudoexfoliative material at the pupillary borders and at the anterior surface of the lens with loss of pupillary ruff.
So how will you state your provisional diagnosis?
It may be pseudoexfoliative glaucoma.
No, you will say it is a secondary open angle glaucoma. It's a secondary open angle glaucoma. Most likely it is a pseudoexfoliative glaucoma with what else?
Nucleus sclerosis grade 3.
Grade 3 in which eye?
In right eye, and nucleus sclerosis grade 1 in left eye.
Yeah, that's how, with diabetes. This is how your diagnosis should be stated in a comprehensive way. So now you have told me about two differential diagnoses. So why is this not pigmentary glaucoma? And another important thing, when you draw a picture, it is important that you draw a picture only of the optic disc.
Okay.
You have drawn an indirect ophthalmoscopic picture, that's well and good, but you have to draw a picture only of the optic disc of each eye.
Okay.
So you can draw, if there is a thinning, you can draw that. If there is a disc hemorrhage, you can draw that. You can draw the peripapillary atrophy. So that is very important. So why do you say a pigmentary glaucoma can be a differential diagnosis? What are the 4 points and what are the against points?
Pigmentary glaucoma is also an open angle, secondary open angle glaucoma.
Very good.
And there is pigmentation of trabecular meshwork in this case.
Very good. Very good.
Sambre lacy line can also be seen in pigmentary glaucoma.
Yes. So what are the negative points?
The age of the patient. Pigmented glaucoma is usually seen in younger age group in the third decade of life.
Very good. What
Then
is the
myopic
common group? What do you say about the common group of people who are affected by pigmentary glaucoma?
Young myopic males.
Yes, very good. Young myopic males. Then any other finding?
Here there is uneven pigmentation in the state, intraocular network.
Yes. Have you heard of transillumination defects?
Yes, ma'am.
So
In
if,
pigmentary glaucoma, usually there is mid-peripheral radial transillumination defect.
why does that happen in pigmentary glaucoma?
Because of the rubbing of the posterior surface of the iris with the
Very
ciliary
good.
frenulum.
Very good. And your other differential diagnosis was primary open angle glaucoma. So primary open angle glaucoma, you have eliminated all the secondary causes, but here you have a cause, you have pseudo exfoliation, so you cannot call it a primary open angle glaucoma. Otherwise, all of it is similar. So now how will you manage this patient? What other investigations will you do? In the right eye, you have a patient who has a pseudo exfoliation, though the new name for pseudo exfoliation is exfoliation, not pseudo exfoliation. So so this patient has an intraocular pressure of 22 and an IOP, and a disc of 0.7 cup. Okay, there is an asymmetry between the two eyes. So how will you proceed in managing this patient?
We can do an HFA.
You should do an HFA.
Yes,
so HFA what?
24-2.
You will do a 24-2 HFA. So considering your patient, what kind of field defect would you expect? See, most of the paracentral scrotum. Why did you say that? It's possible. See, if you see an RNFL defect, or if you see a notch, or if you see an area of thinning, then all these things help you to find out that there will be a field defect in the opposite quarter, opposite half, heavy retina, opposite half of the visual field. Okay. But if you see a generalized enlargement of the cup, it is very difficult to point out where exactly would the field defect would be. Okay. So when you have a suspicious cup, what investigation would you like to do?
OCT-RNF.
OCT-RNFL. Then you would like. One of the most important indications of OCT-RNFL is when you are suspicious of the optic nerve head. And when there is a suspicion of glaucoma in the patient side, then that structural dilemma will be mitigated by the OCT-RNFL. Any other test, any other things that you would do?
Central corneal thickness.
What is it?
Pachymetry.
Very good. Pachymetry. So what is the normal pachymetry value? What is the range of
500 to 540?
Yeah, 520 to 540. That's okay. That's good. So you will do these things. And then when you have done that, maybe you can also do an intraocular pressure measurement at various times of the day to find out if it's increasing, if there is a peak intraocular pressure. You can do a diurnal or an office diurnal. So then you will calculate a target IOP. So how do you calculate a target IOP?
It is individualized based on the baseline IOP value, the age of the patient, when the initial damage.
You look at the commonest way to do it would be to look at the mean deviation of the visual field and the degree of optic nerve head cupping. So depending upon the mean deviation, You can then divide the patient into mild, moderate, or advanced stages of glaucoma. Okay, and then you will decide the target intraocular pressure. So suppose, do you know what is the cutoff for the mild glaucoma for the visual fields?
Mild,
Any other PG?
-6.
0 to -6 is the range for mild glaucoma. Then the moderate,
-6 to -12.
-6 to -12, and then advanced,
More than -2.
if anything more than -12 is advanced. Okay. So what is the usual range of target intraocular pressure in each of these?
mild cases 15 to 17.
So in mild cases, you will go for a 15 to 17 or 18. Okay. Then,
Moderate cases 12 to 15 mmHg.
yeah, very good. And in the advanced
Severe
cases, you will go
10 to 12.
right to 10 to 12. Okay. So what are the treatment options that you have for this patient in the right eye?
Medical therapy.
Okay.
Prostaglandin analogs.
You will give prostaglandin analogs. Okay. But your patient also has cataract. So would you perform a cataract surgery? Your patient
After
has
controlling
22 intraocular pressure. So if you do cataract surgery, would the intraocular pressure come down further?
Yes, ma'am.
It will come.
It can come.
It can come down. So what are the difficulties that you encounter in a patient with pseudoexfoliation during cataract surgery? And how will you manage each of those?
Poor dilatation
Poor dilatation of what?
of the pupil.
Of the pupil. So how will you manage that?
Pupil dilators, iris hooks.
So you said something about visco. See that first. Use the simple ones first and then go for the more instrument. So what was that first? You use a viscodilation technique, or you will use
Iris hooks or
iris hooks, or you will use. Is there any other device? Are there any other devices?
BX
pupil
ring.
expansion devices.
There is B-hex ring or pupil expanding devices like
Alleghens ring is there.
Alleghens ring. Okay. Then what else, Parvati?
Sphincterotomy.
You can do sphincterotomy. Then so, okay, about the pupil. Anything else?
Corneal endothelial decompensation.
So there can be corneal endothelial decompensation. So you must do an endothelial cell count before you perform surgery. And how will you decrease the decompensation?
We can use corneal endothelial friendly viscoelastics.
What are those?
Viscodispersive heel on side.
Yes, you will use dispersive viscoelastics, which will spread on the surface of the cornea, undersurface of the cornea, and protect the endothelium. Anything else? So next, what else?
Zonular dialysis can lead to
Zonular dialysis. So how will you identify zonular dialysis?
in slit lamp. They will
Slit lamp? Yes. So if you can dilate the pupil, well and good. Then you can see how much of the zonular dialysis is there with respect to cloacas. Or if it doesn't dilate, is there any technique by which you can know? Is there any instrument by which you can see the zonules?
ultra micro
Yes, UVM.
biomicroscope.
Right.
UVM.
You're right, very good. Then what other thing? So if there is zonular dialysis, what are the difficulties you can have during cataract surgery?
There can be dialysis and lens subluxation.
What was that? There can be what?
Phacodonosis and lens subluxation.
Yeah, there can be subluxation of lens. So which steps would be difficult?
Capsular X.
Capsular excess would be difficult. So how will you do a capsular excess in this patient?
Larger capsular excess.
You will do a larger capsular excess, but how will you do? You will have to support the capsule. Support
Capsular tension ring.
capsular.
Capsular tension.
So you will use capsular hooks
Yes.
to support the capsule. And then the horizontal stability of the capsule is done by the supported by your capsular tension drill. Okay. Then what else? There is there any other problem that can happen during cataract surgery? Is there a normal chance of developing a PC rent, or if there is a higher chance of developing a PC rent?
Higher chance of developing PC.
Why? Why? Mostly in pseudoexfoliation, the posterior capsule is thinner than usual patients and normal patients. Is there any other problem that you can have during cataract surgery?
There can be decentration of the IOL.
Decentration of IOL. Yes, that is late decentration.
Late decentration of IOL.
Or even sometimes you can have dislocation of the IOL in the back. The whole IOL may come down into the vitreous years later, because
Yes.
the pseudoexfoliation is a continuous process. It's a relentless process. And post-operatively, usually the inflammation is more.
No.
So you will have to give more steroids to tackle the inflammation. Okay. And do you have any other methods to manage patients? You've done a cataract surgery. You've done and given anti-glaucoma medications. What are the other ways to manage pseudoexfoliation glaucoma?
Laser therapy, argan laser trabeculoplasty.
Selective laser. What is the more preferable?
Selective laser trabeculoplasty.
Yeah, you use selective laser trabeculoplasty. So, what is pseudoexfoliation patient a good candidate?
Yes, ma'am.
Why?
They have increased pigmentation.
So, the pigments present in the angle which cause lesser laser to be
Lesser energy is required.
Lesser energy. Do you have any other method of management? In early cases, mild to moderate? Something new that has come up?
Trabecular aspiration.
You can do trabecular aspiration along with cataract surgery, or you can combine cataract surgery with some other surgery. The newer surgeries, what are they?
Microinvasive glaucoma.
Yeah, minimally invasive glaucoma surgery. So you can combine pseudoexfoliation with minimally invasive glaucoma surgery, especially in the mild to moderate cases, and that also gives good results. And you can the patient can be drug-free for quite some time, for a few years. The more the patient is drug-free, the less likely are the side effects of the drug in the patient's side. Okay.
Yes.
So how is pseudoexfoliation glaucoma different from a primary open-angle glaucoma?
It is difficult to control medically. There is poor prognosis as compared to primary open-angle glaucoma, and there will be greater IOP spikes.
So till now, we have discussed all these varieties of secondary glaucomas and pseudoexfoliation glaucoma, thinking that this is a secondary open-angle glaucoma. Can pseudoexfoliation present with closed angles?
Yes, ma'am.
Exfoliation can also present with closed angles.
Closed angles.
Yes. So that is also important. Most of that you've done very well. You've answered the questions very well. So that is good. Only you have to just tweak your presentation and
yes,
just learn from that. Okay.
Okay.
Can any one of you tell me what are the genes implicated in pseudoexfoliation? Which one?
Log cell 1 gene.
Log cell 1. Slice oxidase.
Okay.
And then anything else?
CACN A1A.
CAC, CATNA1. Logs
yes.
and those are the genes that are involved in pseudoexfoliation. I think we've discussed enough for today. If there are any questions, you're most welcome. Anybody with questions? Sahasranaman sir, would you like to
no, Parvati had made a good presentation. The presentation was good. Her answering was good. But in the presentation, the glaring mistake was not mentioning the pupillary reaction. So when she went out with the presentation, people 3 millimeter round. So in any ophthalmology case, pupil is important. More so in glaucoma, pupil is the one which we look at first, even before saying what is happening in the posterior pole. So I probably, how did you miss that? Probably you had written, and when you made the PowerPoint, no, probably you forgot, because I think it can be a bit suicidal, no, Smita, no? In a case
That
of
is why, sir, that is why I wanted to point out that such a thing should never ever happen.
yes. So these things, no. So that was the so in spite of your very good presentation and answering, no, that was a very glaring mistake.
Yes.
So which shouldn't happen, especially for an exam. So it was good. And Smita, your discussion was very good, no? Point by point, no. And so I think we had a fairly good attendance, 38. So that's a good. That's an overall a good attendance. Though we expect more, that's a reasonably good, because I think in some of the this Paathsaala, no, the presentation, the attendance was much more meager. So Elizabeth, this is good attendance, no, Elizabeth?
Yes, sir. Yes,
You
sir.
are satisfied with the attendance, Elizabeth?
Yes, sir.
You shouldn't be satisfied. We should be looking for more. Okay. Yes.
Okay. Thank you, sir. Thank you, madam. Thank you, Parvati, and all the participants. Today we had a very good participants than the last sections. I'm very happy for that. And madam, you had discussed everything very well. And thank you for everyone, and thank you for sir. Thank you, sir, and madam, and also Dr. Parvati. Good night. Can we leave?
Yeah, sure. Thank you. Good night.